Hi, thank you for joining me today. My name is Kristen Waite-Labatt and I am a registered nurse. I'm going to be talking to you today about healthcare workers and substance use disorder and sharing my own personal story. I would like to disclose that I am the author of the book An Unlikely Addict that I do mention in this presentation, and I receive royalties from its sale. And during this presentation, my hope is that you will gain an understanding on the scope of substance use disorder, particularly in healthcare workers, that you'll learn how to recognize substance use disorder, and that you'll discover where to go to get help if you do recognize it. So let's start by looking at the current state of the opioid epidemic in this country. More than 232,000 Americans have lost their lives to overdoses involving prescription opioids from 1999 to 2018. If you look at the graph on the left, it represents the overdose deaths in this country from all drugs. And in 2018, that was over 67,000. As you can see, drug overdose deaths have steadily increased over the years since 1999. In 2018, it really was the first year that we saw a decrease. It was somewhat encouraging. However, 2019 and 2020 are looking to be increased instead of continuing that trend of decreasing. If you look at the graph on the right of national drug overdose deaths, particularly just from opioids, you'll see that 46,802 people lost their lives from opioid overdose. And opioids account for 69% of all drug overdose deaths for that same year. So of the 67,000 drug overdose deaths, 46,000, almost 47, of those were from opioids in particular. And what's startling about that is that in 2014 and 2015, we started to see a rapid increase in the amount of drug overdose deaths from opioids, particularly synthetic opioids such as fentanyl. So let's turn our attention to healthcare workers and talk about drug diversion. Well, what is drug diversion? It's the transfer of a controlled substance from a lawful to an unlawful channel of distribution. So anytime a healthcare person takes a medication that was meant for one of their patients, that's diversion. When they steal it from the stock, that's diversion. When someone calls in a prescription for themselves, maybe pretending to be a patient, that's diversion. Those are some examples. If you look at the graph on the left, those reported diversion incidents are mostly not doctors and nurses. So it's about 67% of all diversion incidents are doctors and nurses. The American Nurses Association estimates that 6 to 8% of nurses use alcohol or drugs to an extent that could impair their practice. Some other avenues say it's up to 15%. The United States has about 3.8 million registered nurses. So if we just look at registered nurses, although they're only one piece, of course, that means that about 266,000 nurses likely deal with substance abuse in some form in this country. And about a third of all disciplinary actions taken against nurses by nursing boards are alcohol or drug related. And prescription drug abuse is about 5 times higher among healthcare workers. So that's not necessarily drugs like cocaine and heroin, but prescription drugs, drugs that they have a little bit more easy access to. So let's look at some current events from recent headlines. In June of last year in Buffalo, New York, the headline read, "Ex-Roswell Park nurse accused of stealing drugs, replacing them with water." September of 2019 in Bedford, Massachusetts, former nurse charged for allegedly stealing morphine from dying veterans. September of 2019 in Cedar Falls, Iowa, nurse who stole pain medication from her elderly patients at 2 area nursing homes sentenced to federal prison. And in November of last year in Greenville, South Carolina, nurse accused of stealing painkillers from Greenville Memorial for personal use. And in May of 2019 in Jacksonville, Florida, former Nassau nurse supervisor arrested after theft of prescription painkillers. I go over these just to point out to you that it is a current problem and it is happening all over the country. And if you work with controlled substances, it's probably happening in your facility as well. And now I'd like to share my personal story with you. My substance use really began in college, where I discovered alcohol. And alcohol relieved my anxiety, and I really liked it. I liked the way it made me feel. So I drank often, drank more than my peers. I drank enough that it took me 6 years to get my 4-year degree. But I did graduate. I did struggle with anxiety and depression throughout most of my adult life, starting, I would say, in college, probably a little before then, but I sought help for those issues sometimes. But once I would start feeling better, I would stop whatever the treatment was, whether it was medication or therapy, and that would leave me feeling those feelings again, or struggling with anxiety and depression again, which I often treated with alcohol. My opioid use really started after a minor surgical procedure in 1997. I found that I really liked the Percocet that I was prescribed. And what I liked about it is that I got that same good feeling that I got from alcohol, but I didn't act silly. I didn't smell bad. I didn't stumble or slur my words. I could act almost normally while taking the pills. And so I used that first prescription and called in for a refill, even though I didn't need the refill for the pain. And throughout the next, I'm not sure exactly how long, but the next number of years, maybe 3-4 years, I would go to my doctor anytime I had even minor back pain and say, I really need some Vicodin. My back is killing me. And she would always give me Vicodin. I first started diverting medication from the job I was working at. I worked in an emergency room somewhere around the year 2000. And I remember thinking one day, I had a patient that needed some kind of opioid, and I kind of said to myself, boy, we throw away a lot of really good drugs. And I started taking them, and all IV. And after a couple of years of doing that, it was always just the waste. So I kind of had myself convinced that it was no big deal because I was just taking garbage, even though, of course, I knew that, but that's part of the denial. And found excuses to waste more. So if a patient had an order for 2 milligrams of morphine, I would pull a 10 milligram syringe and have to waste the rest of it. In 2003, I went through a divorce and really fell into depression. And about that time, I had left over fentanyl. So instead of wasting it, of course, I took it. I took it home, and once I injected that fentanyl, I immediately craved more, and I really started with a addiction, like a craving and a need to have it. And so I started stealing it from the stock at that point. Sometime in 2004, in July of 2004, my diversion was discovered by a pharmacy director who had been watching the pattern, because once I started stealing it from stock, it was pretty obvious. He studied a pattern, and when I was gone on vacation, no medication went missing, and as soon as I came back, it did. So that was kind of their final, yes, we know who it is. So I was fired. I lost my nursing license, and I ended up spending about 4 months incarcerated, which was not fun. But I have been clean and sober since that time, since January 17th, 2005. And after incarceration, I threw myself into recovery, 12-step meetings, intensive outpatient treatment, and really worked hard at staying in recovery, and still do actually today. And I entered in 2007 a 5-year diversion monitoring program through my nursing board, which I'm going to talk to you a little bit more about next. But it allowed me to get a restricted license back and work as a nurse again, because for the 3 years, or roughly 3 years, maybe it's 2.5, that I didn't have my nursing license, I had a really hard time, understandably, finding a job. I completed that program with the nursing board in 2012 and regained my full licensure again, which is a great, it was a great feeling just to have completed that program. It's a 5-year intense program. I currently work in behavioral health at a behavioral health hospital in Wisconsin, and I get to work on my recovery every day at work and at home. I did write a book about my experiences just to help other healthcare professionals navigate through what is a very difficult process, and then also to help others to learn what addiction looks like, what are some signs they may be able to identify in their peers, and just hopefully to help people understand a little bit more about addiction. Let's talk about why and how diversion happens. Why does it happen? Well, relief from stress. Healthcare workers have stressful jobs. Not too surprising, I'm sure. A lot of people, though, have stressful jobs. The other thing that we have is access to the medications that sometimes make us feel better. So we self-medicate for things like anxiety and depression. As I told you a little bit ago, I did. Can follow surgery, injury, or an emotional loss. So the first time I used opioids was after a surgical procedure. That's how I was introduced to them. And my use escalated most definitely when I went through my divorce. That's when I kind of bridged that line, or crossed that line from stealing the waste to actually stealing from stock. We have easy access. So it's not only that we have access to it, but fairly easy access. Now, things are certainly more secure than they were when I was diverting in 2005, but it's still far too easy for people to divert medications. And denial and enabling. So I would tell myself all sorts of lies and completely believe them to convince myself that what I was doing wasn't too big of a deal. Deep down inside, I of course knew that it was, but that denial kept me going, made me able to continue stealing. And enabling, my peers, unbeknownst to them, they didn't know I was using, but they enabled my use by co-signing my waste that I didn't actually waste and not asking me about it, and by maybe seeing some other signs and not being aware that they indicated substance use. And then genetics can certainly play a part. There is a fair amount of addiction on my dad's side of the family. And how does it happen? So how does drug diversion happen? Well, someone who diverts can administer a partial or no dose to a patient. And I certainly did that. I worked in an emergency room, and when we'd have trauma patients, sometimes if I was able to, without people seeing, I would take maybe half of my trauma patients' morphine and give them the other half, knowing full well that they would be able to get more if they needed it, saying to myself, well, it's no big deal because they can have as much as they want. Not really fully letting myself realize that they're going to be in pain longer because I've taken half of their pain medication. So sure, they can get more, but until that time, they're going to be suffering longer. So asking a colleague to sign a narcotics record. So I did this often. I would find reasons to waste medications and have someone co-sign. And nobody ever asked me to see the medication. And I did the same thing for other nurses. We trusted each other, but I most definitely abused that trust. Obtain PRN or as needed medications for patients who haven't requested them. That happens often. Steal medications, as I told you I did. It gets to a point where you start stealing. And altering drug records. I certainly altered drug records to say there were less syringes than the previous count. In fact, when I got caught, they showed me a record I had altered. But when I was doing it, I convinced myself that nobody would notice, nobody would look at it. Ask doctors or providers they work with to write a prescription or to call in a prescription for them. I didn't do that, but I didn't really need to because I was taking the drugs from, that I was getting from my patients. But that certainly happens often enough. So if you are a prescriber, please don't prescribe for friends or family. Steal prescriptions and forge prescriptions. I think most places now do electronic prescribing rather than having a paper prescription pad laying around. If you do still use paper, please consider getting rid of them and using electronic prescriptions because they're just really easy to forge, to steal and to forge. And calling prescriptions to a pharmacy. So I did that on occasion, would pretend to be a doctor, and I had their DEA number, which is what we used at the time, and would call in prescriptions for myself. And then doctor shop or provider shop, going from one provider to another, trying to get medications, more frequently than they should. And this is really much better now with the development of the PDMP, which is the Prescription Drug Monitoring Program that many states take part in, not all, but many. And they share the data too, some of them, not all states. But what it is a huge database that each state maintains. And providers are required to, before prescribing a controlled substance for a patient, look that patient up in the database to see if they have been recently prescribed something, either similar to what they're there seeking or something that could possibly interact and cause harm, like an opioid and something like Xanax. Given together, that can be very problematic. So the prescriber, whoever's looking up that patient, would make sure that nothing else had been recently prescribed. And if it had, having a conversation with that patient to either say, hey, this is a really dangerous combination, you can't take these together, or maybe they really are suffering from a substance use disorder, and then they can have that conversation with them and say, this isn't safe. It looks like you're trying to get too much medication. What's going on with you? Is there something I can do to help you? And maybe offering some counseling and even treatment would be great. So those programs really help to limit the amount of provider shopping that a patient can do. How do you recognize substance use disorder? Healthcare workers have a vital role in recognizing substance use disorder in their peers. We work with each other every day and may be able to notice some subtle changes in each other. So let's look at some of the things that you might notice in a peer that could indicate a problem. Increasing work absences. So someone who is makes every shift is all of a sudden calling in sick on a regular basis. So particularly applies to someone with an alcohol use disorder. They may be too hungover to come to work, or maybe drinking, if they work PMs, may have started drinking early that day. Extended breaks or bathroom visits. So for those with opioid use disorder, they will be there every day working. They may even come in on their days off. But you may notice that while they are there, taking more breaks. This certainly was true for me, especially towards the end of my using. I smoked cigarettes as well, so I would come up with an excuse to go out and have a cigarette every hour, or go for a walk, or I had to go to the bathroom. Whatever it was, I was really just going to the bathroom to use. Shakiness. So someone who was very steady, all of a sudden you're noticing they're shaking. I was shaking a lot at the end, particularly at the end of my using. And I know that people noticed it because they looked and saw me and then looked me in the eye, but nobody ever actually asked me about it. So again, it's a change in a person. So going from no shaking to a lot of shaking may be an indication. Wearing long sleeves when inappropriate. So on a really hot day, wearing a long sleeve shirt to hide needle marks. A personality change, so irritability or agitation. So again, the word change. So someone who was really outgoing and friendly and personable, all of a sudden now is withdrawn and sullen and maybe even kind of snipping at people. Changes in appearance of someone who was well put together is now coming to work disheveled. Falling asleep during downtime. So that classic opioid nod where the person can't keep their eyes open or can't keep their head up and keep dozing off. Again, a change. So it's not that everybody who falls asleep on a night shift in their chair is a drug addict, but if it's a change that you notice, it's maybe something to take into consideration. Volunteers to administer narcotics to a patient. So, saying to you, oh, you've been working so hard, let me go get that morphine for your patient for you. Suspicious drug log entries or changes, I kind of touched on that earlier. Drug discrepancies, so if drugs are missing. Altered verbal or phone med orders. So if you're a prescriber and you call in an order, make sure when you go to co-sign that order that it was put in accurately. So if you ordered 2 milligrams of morphine and maybe the person entered 10 milligrams of morphine. So please be very conscientious of your co-signing. Patients reporting ineffective pain management. So obviously if I'm taking a patient's pain medication, it's not going to be as effective for them. Heavy wastage of drugs, again, something I did. I was always pulling the largest syringe I could. And then incomplete charting and practice errors. So I certainly don't know of any mistakes I made. I don't think that I made any mistakes, but I don't really know that for sure. The truth is I was working while I was impaired and could certainly have hurt somebody. And I think as difficult as that is to acknowledge, I think it's really important because that's what we all get into healthcare for, is to help people. And when I'm working impaired, I may not be able to do that. In fact, I may be causing harm. So it's probably the biggest thing to keep in mind is that if you have a coworker that is abusing substances, they very well could be hurting their patients. And what do you do if you recognize it? Well, many states have mandatory reporting laws that require reporting to your board of nursing. If you're a coworker on the floor or on the unit with them, are really mandated to report signs of abuse to your supervisor. And then the supervisor, the leadership, is responsible for reporting to the nursing board. And follow your workplace policy. Most places have a policy on what to do if you should discover it and the steps to take. But the truth is, it can be really hard to turn in a peer, particularly if they're a friend of yours. Number one, you need to remember that they're putting their patients at risk. So as difficult as it may be to report them, you may very well be saving or protecting, you're for sure protecting your patients and maybe even saving them. And the same could be true for the person who is diverting. So the second thing I would ask you to keep in mind is that the person who's diverting, most of them by far, are not happy about it. They feel terrible. I know that I felt horrible. Even though I tried to justify it in my mind, I knew what I was doing was wrong, and I was miserable. I was absolutely miserable, and I couldn't stop what I was doing. So yes, it's difficult in the beginning, but you're going to be helping them and possibly saving their lives too. Now let's talk about nursing drug diversion programs. They can go by different names: drug diversion program, monitoring program, alternative to discipline program. Most states have them now. Not all do, but most do. So find out if your state has one if you don't already know. But the programs are really helpful for nurses. They help them to return to nursing practice safely. There are two main types: confidential and public record. Confidential programs are for those nurses who report before they get in trouble or before they have legal issues or before they start diverting. And then the public record programs are for those like me that had legal problems that the board had to show they were doing something about. So the programs allow participants to obtain treatment, usually lose your license for at least a temporary short period of time. But if you follow the rules of the monitoring program, you're able to get your license back and practice. So it monitors the participant through treatment. It doesn't provide treatment, but will monitor them through it. So if there is any kind of relapse, they can address that immediately. Some requirements of these types of programs, and again, they're all different. Commitment to the program for up to 5 years. So Wisconsin, where I did my program, was 5 years, a 5-year commitment. Other states have 2 to 5 years, or 3 to 5 years, dependent on what that nurse was involved in. And then random urine drug screens. So for my program, I had to call every day and was chosen 1 to 2 times per week to go and have a sample or provide a sample. Then also we have to go to 12-step meetings, 1 or 2 a week. We have to have a treatment-based assessment, and then to do whatever that assessment says we should do or whatever they recommend. You have to submit reports, both the participant themselves and their therapist and their employer, manager. And then they have to pay for all that, which can be the biggest hurdle, particularly if you've lost your nursing license and can't practice as a nurse anymore. Some of the limitations that will be in place on your restricted license: no access to controlled substances for obvious reasons, no working for any type of staffing agency, because your work has to be supervised by a licensed professional. And when I say supervised, I mean 24/7, like they have to be right there with you watching you practice. So that can be difficult too, to find a job that meets all of those requirements. Let's talk about prevention of drug diversion. One of the first things I would mention is requiring random urine drug screens for those with access to controlled substances. So nurses, doctors, providers, pharmacists, pharmacy techs, etc. Not a very popular idea or suggestion. People that don't have a substance use disorder feel it's an invasion of privacy. They shouldn't have to do it if they're not stealing, they're not diverting. And while that's probably true, unfortunately, what I would say to them is the world that we live in today is really requiring us to do this to keep our patients safe. Put cameras in med rooms. I think most med rooms have cameras now, but make sure you look at the video periodically. No good having a camera in there. It's not much of a deterrent if people know you're not looking at the video feed. And never co-sign as a witness if you haven't actually witnessed a controlled substance being wasted. I mentioned this was a common way that I diverted, and I know that is true for a lot of other nurses as well. If you haven't seen the med being removed from the Omnicell or the Pyxis, given to the patient and then wasted, don't sign for it. And suggest that same thing to your peers. We really need to become more willing to be uncomfortable and tell our peers that we can't do that because I didn't see you waste it. Secure all sharps and pharmaceutical waste bins. I've heard many stories recently of people in housekeeping and maintenance, the people who are responsible for changing out the sharps bins, overdosing in the bathroom after getting some kind of a medication out of those bins. So secure them, but then also have a witness whenever they're changed out. Develop a drug diversion intervention and response team. So someone that is responsible for reviewing every diversion incident that happens and coming up with interventions of how we can avoid future diversion incidents like that. And then have a 24-hour confidential reporting line. Because as much as we'd like to think we would be proactive when we see something, it can be really, really hard to report a peer or a good friend. So having a 24-hour confidential line would make that much, I don't know if easier is the right word, but it would make people more compliant with that, I believe. If you would like more information on substance use disorder in healthcare workers, feel free to check out the references that are detailed on this slide. You can also get my book, An Unlikely Addict, on Amazon. My phone number and email address are here as well. I would welcome a conversation, so feel free to reach out. Thank you so much for taking the time to review this video today. I wish you well, and I hope you stay safe. Thank you. Bye-bye.